The first one, by the way, is not very small. And that is when we talk about recovery-oriented system, or systems, plural, of care, I want to underscore that when my recent writings, as I think about that, the system I'm talking about is not a system of addiction treatment. The system is a larger community in the macro-level organization of a state or a nation. And the treatment system has a role in that. But the system, there will never be enough resources to create the recovery supports we need to sustain long-term recovery solely inside a treatment system. It is the community level, in the neighborhood, in the community, in the state, in the nation, is that recovery-oriented system of care we're seeking. And our role is to play a significant role in mobilizing the resources of those larger entities. I also write a lot and have really advocated the use of the term recovery management as an alternative to the acute care model. I want to be very clear about one word, and that is the management in that is very different to terms like case management, for example. Because in recovery management, as I'm going to underscore later, we're not doing the managing. The managing actually shifts to the client and the family, and we become consultants to them in that process. This is not about control, and I think that'll be really underscored as we get into that discussion a bit later. We're about to release a new monograph that we have out that I've spent a good chunk of my last year working on. You've got an executive summary, and in that, what I'm really suggesting is that we really, in terms of a macro and micro level organization of this transformation process, really requires three things. And that is sort of national, state, and local infrastructure strength and adaptive capacity. And I must tell you, the vote is not in whether we have the infrastructure strength or whether we have the adaptive capacity to pull this off. And in that monograph, we really describe what are the elements of that are going to be required. Recovery-focused service process measures, and that is intermediary, measurable service outcomes that are clearly linked in the science to long-term recovery outcomes. And we're going to talk about some of those this morning. And of course, the third area is a consistent and clear definition of long-term recovery outcome measures over time. I'm going to compare and contrast an acute care model of addiction treatment and an emerging recovery management model. I want to begin by defining what that acute care model is and see if you would agree if that is, in fact, the prevailing model that we have. I want you to actually think about an acute care model as an emergency room. Because my observation is that essentially is what we've evolved into. We're not only an acute care model, but we're more acute every month that goes on in terms of, particularly of the last 15 years. Oh, by the way, here's a meeting list to try to get sponsors if you can. And that happens over what period of time? Well, it depends on what year, what decade of my career you're talking about. But over those decades, what's happened to that dose? The length of that relationship has got shorter and shorter. A professional expert drives the process. We really bought into a medical model in the early 1970s on our way to professionalization and to become an industry. And we modeled basically a kind of medical psychiatric model in which the professional diagnoses, prescribes a course of treatment and directs that treatment, and then offers some kind of continuing care recommendations for their patient. Services transpire again over a relatively short period of time, and the individual, family, and really community by way of referral sources is given the impression at the end that recovery is now self-sustainable without ongoing professional support or monitoring. And that's indicated by our historical use of the concept of graduation. And the good news is that model works. That brief acute care model of intervention has generated very significant measurable effects for large numbers of individuals. I think it's also important for us to acknowledge that there are people's lives, individuals and families' lives, including my own, who have been transformed by this system. We owe our lives to that system as it existed. So I take this critique on within the family. Are you with me? Because many of us have deep gratitude for the blessings that treatment brought us. But that does not eliminate the responsibility at times of our need to take a searching and fearless inventory, if you will, of addiction treatment as we know it and how its design has evolved. We see, in terms of the outcome literature, that there are significant measurable outcomes, and we've used the term treatment works to really elevate and promote the viability of addiction treatment. Many of you know I have really challenged that use of that slogan. Really, as a historian, my fear was that that slogan was overselling what an acute care episode of addiction treatment could generate. My concern was that it conveyed the idea that there was a homogeneous entity called treatment that was consistently delivered throughout the United States, and that it worked. You and I both know that consistency is not present throughout the United States. There's enormous variability across programs and even across clinicians. When I say treatment works, but we're now going to move to, we're going to look at 10 critical areas of clinical systems performance. We're going to look at the data related to the acute care model, and we're going to say now in the world that's unfolding today, for those who are trying to transform this system, how are they changing practice in that area? And we're going to look at those, as I said, in 10 areas. We're going to begin by the issue of attraction. And you've all heard these numbers, so I'm not going to belabor these. We know right now that the vast majority of people who meet DSM-4 criteria for abuse or dependence in any given year, only a very small percentage of those actually receive services. I'm actually more troubled by the Dawson study that really documents that actually only 25% of individuals who meet that criteria will ever see the specialized addiction treatment sector in their entire lifetime. Why do people not seek treatment? There are a number of factors that we've identified, but there are at least 4 that I want to make note of. And that is, if you go to the consumer level, why are individuals with these problems not reaching out and seeking services? It's how they perceive the problem, meaning not severe enough. Their perception of self, this is something I can manage. Their perception of treatment as ineffective, unaffordable, inaccessible, or even within a growing number of drug cultures, a kind of growing pervasive sense that treatment is really for losers. Perception of others, and that is again the growing phenomena of the re-stigmatization of alcohol and drug problems through the 1980s and 1990s. It is making it harder and harder for people in mainstream communities to step forward and walk into addiction treatment in the United States. Perhaps most of concern, I want you to think right now, do we have any system-wide strategies to reach alcohol and drug consumers to alter these perceptions? And I'm going to suggest that we have some progress beginning in a couple areas, but historically we have not had strategies to really address those. Coercion versus choice. The fact that the vast majority of people who enter addiction treatment in the United States today do so under external coercion is not an indictment that says coercion is not an effective medium of treatment. We know that it is. But here's the question. If an ever-growing number of people are only coming to treatment under external coercion, what does that tell us about the stage of problem development at which they're seeking services? And right now, if you look at that coercion data, it's been progressively increasing throughout the last 2 decades. What we conclude by that at this point in time is the acute care model of addiction treatment as we know it does not voluntarily attract the largest percentage of people who suffer from these disorders to seek services within it. If we look at the recovery management strategy, is really critical. Let me actually start with the bottom and why early intervention is so critical in the recovery management model. It's critical in any chronic disease intervention because essentially it says that the earlier the stage of intervention, of problem identification intervention, the greater the prognosis for long-term recovery. We have data now saying the earlier the first treatment, the shorter the long-term addiction career, even if that first treatment isn't so-called successful based on the traditional ways we evaluate them. So early intervention is very important to us. In some terms of some of the kind of strategies, we are beginning to see aggressive anti-stigma campaigns emerging at local community levels. And if you haven't seen the Recovery is Everywhere campaign out of Ann Arbor, Michigan, I really encourage you to type in Recovery is Everywhere in quotes, or recoverieseverywhere.com, org or com, I can't remember, org. And I think you're going to be amazed at what they've done in terms of a local anti-stigma campaign. Early screening and brief intervention, tremendous data on the utility of that. But I want to emphasize, brief intervention is not just to identify people at the earlier stages of the disorder, and not just for non-dependent individuals. We're getting a growing body of recent evidence that says, we assumed this really wouldn't be effective for people who were dependent. The question is, can screening and brief intervention actually increase the help-seeking behavior of people with very severe alcohol and other drug problems? And it appears very promising in that area. Assertive models of community outreach. We're going to talk later. It's about time we simply left our offices and went and got people. I can tell you by zip codes in the city of Philadelphia, where we have inordinate concentrations of addiction-related problems. And we're now beginning to scope out and lay out the aggressive outreach programs that are not going to wait for people's pain or coercive institutions to deliver them to us. We're simply saying it's time we went and got them. We had a Net Consumer Council member speaking and welcoming us. One of the things the Net Consumer Council is doing is they're beginning to organize outreach programs where clients and groups go into the streets and the communities, some of the very street corners off of which they came, and carry a message of hope for long-term recovery. That's incredible. We're beginning to see a growing movement of delivering services in non-stigmatized, non-specialized sites. If we look at a second area around access and engagement, we have had historically significant obstacles to issues of access to treatment, particularly in the research we've done on waiting lists. We know that there's a high dropout rate for people who initially call for services, but actually never make that. The good news is, as we begin to see projects like Niatech, we're dramatically re-engineering the front end of addiction treatment through some very clear and simple technologies that are wonderfully opening the doors ever wider of addiction treatment and enhancing early retention. We know, for example, that if we look at the issue of engagement in terms of treatment, right now that we have more than half of clients who come into addiction treatment in the United States do not successfully complete treatment. 48% complete, 29% leave against the staff advice, and 12%, which I'm very delighted because only a couple of years ago that figure was 18%, are administratively discharged for confirming their diagnosis. As a historian, I have to make a brief comment on this. People look back and say, in my writings of history, when we were treating morphine addiction with pounds of prescribed cocaine in the 1870s, people say, what the hell were they thinking back then? And I always wonder, it's easy to spot those looking back. I wonder in 50 years what people will be saying about us. So I'll jump 50 years ahead, and let's look back, and here's the situation. We admit people to addiction treatment because we allege they have a disease. And the essence of that disease is the inability to abstain from alcohol and drug use in spite of escalating consequences. And once use starts, there's a loss of a shutoff valve. And that's really the essence of this disorder. So people come in and tell us they have this disorder, and we admit them to treatment. And within the next 24 hours, they consume alcohol or other drugs, suggesting they really do have the disorder for which we just admitted. And as a result of confirming their diagnosis, we throw them out of treatment. Is there any other healthcare sector where you can be administratively discharged for exhibiting the symptom of the disorder for which you were just admitted to be treated? History is going to judge us very harshly for this. I want to talk about also a kind of shifting thought about motivation. The high AMA and AD rates historically we use as a kind of screening tool, as kind of a premium. Those who really want it are going to stay. We use it as a kind of motivational filter. And that sort of seemed okay until we did the data that really says who are the people that are leaving and that we're throwing out. And the answer is they're the people who need it most. Because if we look at problem severity, problem complexity, inadequate recovery capital, the very people not complete are the people who need it the most. If we look at the recovery management strategy of this, we could just write Niatech over this page, okay? What we're talking about is aggressive waiting list management, streamlined intake, dramatically lowered thresholds of engagement, which, by the way, is enormously controversial with frontline clinicians. When we have a client who says, I understand why you're talking to me about cocaine, why are you talking to me about reefer? Reefer's never been a problem in my life. In fact, I sort of consider it my solution. And the only way we'll bring that person into treatment is if they agree to total abstinence as the goal for all substances. That's the old world. In the new world, if somebody's ready to start work on cocaine, we admit that person to begin work on cocaine. I'm going to suggest that is a dramatic shift in terms of a lower threshold of engagement. Not that we used to have high thresholds of engagement. I entered the system of treatment at a time that I walked into a facility and there were people wearing diapers, with signs and shaved heads. And you had to call multiple days ahead, right, George, to be able to get an intake. And then I got to the prospect chair, and then you sat on the prospect chair for hours, and then you went into this group interview where you got sort of psychologically ripped to shreds, and then you had to stand on a chair and scream as loud as you could, "I need help," with everybody saying, "We can't hear you." Now I'm suggesting that's a fairly high threshold of engagement. Again, what we're beginning to see is a sort of a radical rethinking of this whole kind of intake process and an altered view of motivation. We've historically said that motivation is a key. Lack of motivation is a grounds for admission or entry into addiction treatment. I think in the new world, we're not saying motivation is not important, but we're saying motivation should be a treatment outcome, not a pre-existing requirement for a ticket of admission into addiction treatment. It's an outcome of a relationship, not a required entry to get into that relationship. That is a fairly dramatic shift. At the assessment level, our historical acute care model says that it is a categorical assessment, meaning it's very narrowly focused, particularly historically in the addictions area. It is pathology focused. Our goal of that interview is to generate a problems list. And as you well know, many of you have been on the front lines, that problem list is then going to drive the service plan for us. It is professionally driven, meaning it's the counselor who's constructing this plan, and actually ask the client to sign it to create the illusion of participation through that process. And it's essentially a one-time event. It's an intake function. And that is the assessment process within the traditional AC model. If we look at how that shifts in a recovery management model, it shifts from categorical to global because of a simple premise. And that premise is chronic diseases beget other acute and chronic diseases. Therefore, all assessments in that context, by definition, must be global. It shifts from a pathology-based to a strengths-based format. We're right now in the United States sort of radically rethinking our assessment instruments around the issue of how do we begin to measure individual and family and community recovery capital as part of this process. A greater emphasis on self-assessment versus the diagnosis of the professional. The scope of assessment shifts from the individual as a unit of service to a family-based and in many cases community-based assessment process. If we really believe addiction treatment, and particularly addiction recovery, is marked, as George and others have written very eloquently about, by predictable stages in the long-term recovery process. And if we believe service needs significantly shift in the movement from one stage to the other, how can we assess one time as an intake function? This model really requires a dramatic shift, and Tom and others have written about the importance of this continual evaluation process, and that really is where we're going. And we're seeing a rapid transition from treatment plans that focus on biopsychosocial stabilization, that are, in many cases, that are generated by a professional and need to be, rapidly shifting to recovery plans that are client-developed and client-directed. And they complete them. Some of you actually saw the forms last night at the Recovery Center. The clients fill them out, and if we're very nice to them, they give us a copy of their plan. If we look at the service elements, I'm just going to talk about a couple of these. We've obviously talked about the incredible issue of the gap between research and science, the lack of evidence-based practices in many mainstream treatment programs. Tom, Bill Miller, others have eloquently reviewed many of this gap. Minimal individualization of care and a reliance on sort of the program. People come and go through the program. And only superficial responsiveness to special needs. Meaning that as a system, if we're in a state, we will fund one or two special treatment programs for women who really learn how to treat women. The problem is any woman that goes into any other treatment program in the mainstream treatment sector has no access to those understandings and those service technologies. if we begin to look, we do have an emphasis around evidence and evidence-informed and promising practices in the recovery management model. But I want to tell you at the same time, we do that with a degree of humility, because when you begin to shift to the recovery model, what you are acutely aware of is how much science has not yet been completed, hasn't been weighed in on some of the most critical questions. We also know that many of the evidence-based practices, I work in a lot of Native American communities. If I go to the evidence-based articles, the studies, how many Native American communities do you think participated in those studies? So there's some really substantive struggles around this issue, very complex issues. A high degree of individualization. I think some of the programs that are going through this, there's an initial place where there's almost a mourning of the loss of the old model. We mourn the loss of the program, because what we found was the program may have had more to do with the staff than the clients, because it was a very way to organize a service milieu for the convenience of the staff. But now we suddenly have an ever-growing menu of services that are uniquely combined and sequenced and supplemented, that places an enormous degree of greater responsibility on individual clinicians than they have ever had before. We're also seeing an emphasis on mainstreaming highly specialized services such as co-occurring disorders, issues of cultural competence, developmentally appropriateness, etc. Composition of the service team, I just want to make a couple quick observations on differences. In acute care model of addiction treatment, we use a lot of medical metaphors. Would you agree? We use a lot of medical language that really couches the world of acute care addiction treatment. But the reality is, most people in primary addiction treatment in the United States spend almost no time with physicians' assistants, nurses, or other medical personnel. At the same time, we're using a lot of rhetoric around recovery. And yet, the percentage of representation of recovering people in addiction treatment is dramatically eroded. Not only in our hired staff, but the loss of volunteer programs and alumni associations and consumer councils. And the days when the centers were like 24-hour drop-in centers for individuals and family members in recovery, who came in every hour of the day. When I was putting together the history of Parkside system that collapsed in the early 1990s, at their height, they had more than 200 AA volunteers that were scheduled 24 hours a day, 7 days a week inside that facility. What do you think that meant by way of support? When all of the staff were caught up in staff meetings and doing all their escalating paperwork requirements. Today, when staff were caught up with those requirements, nobody's out there. If we look at where recovery management model is going, at least on a couple of those issues, one is we're beginning to take the position that everyone in long-term recovery should have a relationship with a primary care physician. And to the greatest extent possible, that physician ought to be knowledgeable about addiction and recovery. Not necessarily an ASAM certified physician, but a physician who is generally knowledgeable and in their role can perform an annual recovery checkup as part of an annual checkup of this patient and their family. We're beginning to talk about primary health care clinics within addiction treatment. We're beginning to talk about linkages to get primary physicians lined up for people coming into treatment. We're beginning to see new service roles that are bringing recovering people back into the system. Can I just candidly tell you that addiction treatment in the United States today is a much colder place today than it was when I entered treatment in 1969. Through our professionalization, we have cooled the treatment milieus of this country. I believe one of the functions of recovery coaches and peer-based recovery support services is to begin to warm that environment back up and rehumanize it. We're beginning to see renewed emphasis on volunteer programs. We're seeing dynamic things like the consumer councils here in Philadelphia, particularly the Net Consumer Council. And the amazing thing those clients are doing to support each other and to reach out to other people who are still suffering. We're seeing, particularly within communities of color, efforts to reach out to indigenous institutions and indigenous healers. We have a growing body of research, for example, suggesting that there are culturally prescribed styles and pathways of long-term recovery. If we know, for example, that significant numbers of African American women will migrate from early AA and NA groups and recovery homes to their churches as their primary sobriety-based support structure. How can we not be involved with those institutions? How can we not begin to involve those institutions in the life of our organizations? In Native American communities, we have a vibrant, abstinence-based cultural revitalization movement called the Wellbriety movement. How can we do addiction treatment with Native Americans and not bring those indigenous healers from those tribes into our treatment environment and begin to blend those methods of healing across Western and Native medicines? Number 6, the service delivery site. The acute care model has historically been institution-based, as by the way, as we have nicer and nicer institutions. We've had a very weak understanding over time of the sort of ecology of recovery and the physical and cultural environments in which people are going to be initiating recovery. The AC model question, the acute care model question, is if somebody calls, you call and you got a brother in crisis. My issue is, how do I get your brother from his world to my world? How do I get him to the treatment center and get him into treatment? In the recovery management strategy, we begin to reframe the question substantially different. One is we begin to move out of institution-based environments and place a much greater emphasis on home and neighborhood and community-based treatment outside of specialized treatment. And the question is not how do we get this person into treatment, but how do we nest the process of recovery within that person's natural environment? And failing that, how do we create an alternative culture of recovery that can embrace and support this person? The Native American communities have this wonderful metaphor of the healing forest. If you've heard Don Coyes, you've heard Don talk about his description of the acute care model is we take a sick and dying tree and we dig it up and we move it way over here and we transplant it into healthy soil and we give it sun and water and nurturing and we bring it back to life. And then we dig it up and we take it back and put it back in the hole from which it came. And that's Don's metaphor of saying it's time we began to treat the soil as well as the trees. He's calling for a healing forest where we begin to think about interventions in broad family and social networks and communities as well as with individuals. Service dose and duration, and I'm going to have to move quickly through this, so hang on. One of the best predictors we know from studies, including studies of people in this room, and I'm thinking, George, some of your early studies out of the TC, dose was incredibly important as a predictor of long-term recovery outcomes. And we had NIDA's excellent principles of addiction medicine that emphasized the dose principle and defined dose for non-methadone treatment modalities as around 90 days of contact across levels of care. So the question is, in an acute care model that's become ever briefer, how many clients currently get 90 days of service contact in the United States? And you know the scary thing? In most places I go, we can't even find out. Because we're only measuring dose of contact inside a level of care. Nobody can tell me what the total dose is across levels of care. But the best data we're able to put together is large numbers of people. In this system, we're getting significant less dose. What I want to suggest to you as we move forward here is we are putting people in modalities of such low intensity and duration that there is, for all practical purposes, minimal likelihood of any recovery outcome as a result of that. And then when the inevitable relapse occurs, the individuals get blamed. And we remove their children. And we send them back to prison. And we take away their jobs on the grounds that they had their chance. And what I'm arguing this morning is it wasn't a chance. It was a setup. Those are not individual failures. Those are system failures. And I would be remiss if I didn't talk about the disproportionate number of people of color who get punished in that precise way. If we look at the majority of people completing addiction treatment as an outcome, resume using alcohol or other drug use in the year following treatment. This next figure is a stunning one to me. We have some studies that suggest that of all the people who will ever relapse following addiction treatment, 80% will do so in the 90 days following discharge. If there was any other disorder where the post-treatment vulnerability was that high, how aggressive do you think our post-treatment monitoring and support would be? It would be unprecedented. And yet in this very period, this is the time for the most part, because I'm going to tell you later, they're not in continuing care programs. We basically tell them goodbye and have a good life. Most persons treated for substance dependent who achieve a year of stable recovery do so after multiple treatment episodes. A growing body of addiction careers research out of California and Chicago and Philadelphia and New York City. So the question becomes, how do we begin to then shorten addiction careers, and how do we lengthen recovery careers in this process? Individuals leaving addiction treatment are precariously balanced between addiction and recovery at a time we are no longer in their lives. But other people are in their lives. Because I'm going to tell you in a second, we're not doing post-treatment monitoring, but other people are. Drug dealers are doing post-treatment monitoring and early intervention, right? Drug-using peers are doing post-treatment monitoring and early reintervention. So I'm saying the person we release and hug from our wonderful graduation ceremony is re-entering a world with many active forces promoting relapse. That's reality. I have no problem with that. But the problem I have is we aren't there to counterbalance those forces, almost guaranteeing the risk of relapse in many cases. In terms of timing of recovery, crucial question for the chronic disease model. When does sobriety today predict sobriety for a lifetime? When is this thing we call recovery stable? How long should professionals remain involved with those they serve? I would argue, for any healthcare condition, professionals should stay involved actively until the individual and family can manage that disorder over time with their own resources. So the question becomes, when then is recovery stable that we as professionals can disengage from the support process? The alcoholism literature we have, as meager as it is, consistently comes in the 4 to 5 year range. If we say, when does the risk of future lifetime relapse drop below 15%? Fairly consistently 4 to 5 years. When we look at the opiate literature, on the other hand, we actually see a little bit higher relapse rate. We've got the work of Simpson and others saying 20 to 25% of narcotic addicts who achieve 5 years of continuous sobriety, clean time, will later relapse sometime in their lifetime. What would this data suggest to you about how long we need to be monitoring? In a parallel way that we monitor cancer routinely in the United States with the same 5 year benchmark. And yet, how long are we involved? Fragility of family. I've talked mostly about individuals, so we're about to make a shift here very quickly. Historically, in the acute care model, we suddenly got this notion that addiction is a family disorder. Thanks to Sis and other people in here who've been very much a part of teaching us that. And so we began to say we need to involve the family, who used to be thought of as the enemy of treatment. Our job was to keep them out and break that contact. So we created family night and family week programs. I ran a lot of family week programs, and we brought the families in. We did all of our education. We did our family sculpting. By Wednesday, they had them all crying. By Friday, they were all hugging. They were going to live happily ever after. And that was the notion. We had the assumption that when recovery is stable, family healing will naturally take care of itself. We could not have been more wrong. We don't have a lot of research in this area, and Lord knows we need plenty more of it. But the fledgling research we have from Brown and Lewis and others tells us this. Recovery alleviates many of the problems, but this horribly unstable, chaotic environment, if you will, is a time of uncertainty and turmoil and can continue for up to 3 to 5 years. Look at this language, the trauma of recovery on the family. There's not a person in here who probably hasn't witnessed what I referenced with the researchers yesterday. And that's families who've absorbed everything addiction has to give and still hung together as families. Sick as they all may have been at that point. But they were a family, only to enter recovery and then have that family disintegrate. And what this research is telling us is recovery is very destabilizing to families. So if we're going to talk about the need for monitoring and support, who does it need to go to? We're not talking about just individuals. We're really talking about ongoing monitoring, support, and early reintervention with individuals and family units as well. Aftercare is an afterthought. Great news here. Many of us know. Post-treatment continuing care can significantly elevate long-term recovery outcomes. Great news. Bad news. Almost nobody gets it. The data says, again, ranging depending on the sources. A Jim McKay study, 1 in 5 adults in the United States gets any significant dose. I think you talked about it as at least 5 contacts post-treatment. SAMHSA studied 1 in 10 from 2005. In our adolescent studies out of Chestnut, we're finding only 36% of adolescents receive a single post-treatment continuing care contact following discharge from a primary treatment modality. What we have as a result of that, of the shortened dose and the lack of continuing care, is addiction treatment was birthed historically as an alternative institution to stop the revolving door of drunk tanks of the 1950s and 60s and the inordinate burden on general hospital emergency rooms. And you know what? We stopped a lot of that revolving door. What did we create? If 64% of those in addiction treatment today have already been in treatment one or more times, maybe the scariest figure is we're up to close to 20% of our clients have already been in 5 or more prior treatment episodes. What's going on? What I'm suggesting is we are recycling a growing number of people severely impaired with very complex problems and extremely low recovery capital, multiple times at great expense through an acute care model with no measurable long-term recovery outcomes. Where do we go with this as we shift into a recovery management model? We're seeing movements towards post-treatment monitoring and support, stage-appropriate recovery education, very assertive linkage to communities of recovery and new recovery community institutions. And we're beginning to talk, and when needed, very early reintervention. What we're trying to do is re-intervene at the time the problem severity is now still low, and recovery capital has still been retained from the last episode. So hopefully these re-interventions are briefer and much more prolonged than we have historically. The focus is shifting from managing a single episode of biopsychosocial stabilization to a broader view of how do we begin to actually support the long-term course of recovery for individuals and families that may cross multiple discrete interventions of care. I want to really dramatize and offer the challenge to those who say, we're already doing that. Let me give you an example of how radically different assertive continuing care is compared to traditional continuing care or aftercare. First of all, it's provided not just to those who graduate, it's provided to everybody that's admitted. Who is in greatest need of assertive continuing care, for God's sakes? Those who completed or those who bombed out in treatment? Number 2, the responsibility for contact is no longer with the professional staff, it is with the clients, it is with us. If Mike and I are both running aftercare groups, and we said, did you see Bernie in your aftercare group? And Mike looks at me and says, he wasn't in my group, and he wasn't in my group. Mike and I mourn the loss of poor Bernie. And neither one of us is picking up the telephone. Neither one of us is getting in our car and going to find Bernie, because you know what? In the modern world, if we did, it would be a boundary violation for us. Neither one of us would be involved in assertive post-treatment contact by telephone or internet with him, because we would be afraid of getting sanctioned for ethical violations related to how well we're handling these relationships. Timing. We're trying to capitalize on a critical window of vulnerability, the first 90 days following discharge. So if you have limited resources within your system for post-treatment monitoring and support, when do you want to saturate it? All of the data tells us, saturated in the first 90 days as the time of greatest vulnerability. I think it's so wonderful that we keep coming up with this 90-day figure from all the best science in the world. Is anybody smiling with me right now? That 90 has some familiarity with some of us from some other contexts. Number 4 is intensity, the ability to highly individualize post-treatment monitoring based on somebody's unique, predictable points of vulnerability. The clients are the best experts on their own vulnerability. They can tell us in the next 12 months dates and times and events at which they will be most vulnerable. We can orchestrate and plan recovery support services precisely around those points of vulnerability. Number 5 is duration. I think every piece of data that we have builds a rationale at a minimum for 5 years of post-treatment monitoring and support, even though for clients that are highly stable with good recovery capital, that may constitute nothing but an annual recovery checkup. But I believe at a minimum, that's how long the science tells us we should be involved with the clients we serve. Location moves from community-based, moves from a clinic-based follow-up system where we expect people to come to us, and where we begin to, in fact, go to them. Staffing in these models can be either professionally directed or peer-directed. And finally, we're getting a growing use of telephone-based follow-up systems and internet-based systems of continuing care. Next piece, number 8, relationship with recovery communities, great news. Participation in these communities elevates long-term recovery outcomes. Bad news. We have poor linkage rates from treatment to these communities, and we get high attrition rates over the first 12 months of contact. Good news. Active linkage to these groups. Linkage of a client to a particular person or a particular group, and carefully matching this client to that person in that group can significantly elevate affiliation rates and recovery outcomes. The bad news is when we look at mainstream treatment practices, most of the linkage processes are not assertive, they are passive, consisting of, here's a meeting list, try to make some meetings if you can. The recovery management strategy for that, I don't have time to talk about, just read this. I'm serious. The entire book is on, the whole piece is how do we do this linkage between addiction treatment and communities of recovery. And all the steps basically are there. The service relationship in the acute care model is a kind of authority-based dominator model. Recovery is based on the hierarchical time limit, transient, and highly commercialized. In the recovery management model, the role shifts dramatically. It shifts to a kind of partnership model, much more consistent with the relationship between physicians and their patients involved in long-term disease management with diabetes, hypertension, and others. Recovery management is focused on this phrase, continuity of contact in a primary recovery support relationship over time. Now, I want you to think about two problems. One right now is the highly fragmented levels of care system we have. Every time we now move people from levels of care to level of care, we usually sever that contact. The other thing that happens is with the high turnover of staff, what happens? Even with clients who come back from multiple episodes of care. The bizarre thing in the research world is we have research staff who follow clients 5, 8, 9, 10, 11 years now. And these staff have been in their lives longer as research staff than any treatment professional has ever been in their life. That's a very sad commentary. The good news, we have research technologies coming out of our research community. If you do not want to be found, don't participate in our studies. Because we will track you into hell and find you. I mean, if you look at the kind of contact rates out 5, 10 years, 94, 95%, with homeless populations, that's unbelievable. Why aren't we transferring that technology into the clinical world to maintain those rates of clinical and recovery support contact? Finally, the way we traditionally evaluate addiction treatment, the historical focus, as Tom has very articulately described, Tom McClellan in the back, is we historically evaluate isolated episodes of treatment. And if we get a good come immediately afterwards, usually short-term outcomes, that was a successful treatment. If not, it was an unsuccessful treatment. In the new world, what we're really beginning to evaluate and conceive of is if somebody has 5 treatments, the first 4 may not have been failures, and the 5th, by the way, might not have been a success. Are you with me? What we're beginning to look at is the whole notion of cumulative effects of interventions, unique sequencing of interventions that create heightened potency to kind of jumpstart somebody from recovery initiation to recovery maintenance. I want to leave you with, I have a minute, with 4 closing thoughts in summary of all this. Anything I haven't covered is in the far too many publications I've written about this. Unfortunately, you've been burdened with to carry home. But here are the take-home points. First, when we're talking about recovery-oriented systems of care and recovery management, I want to emphasize, as a historian, I need to say to you, this is not a refinement of addiction treatment. That one of the fatal flaws in the modern evolution of addiction treatment was we had a couple of paths to take, and we took a path that took us into an acute care medical model, acute medical model of intervention. That is a fatal flaw. and that fatal flaw must be undone. I also believe that historically, that acute care model is historically unsustainable. Everybody hear me? It is historically unsustainable because we have oversold to this country what it can do. And it's only a question of time, and we may already be there, where everybody in this country knows someone for whom treatment didn't work. And when we reach that point, we are on a kind of probationary status as a cultural institution, and we are vulnerable to have that probationary status revoked if we do not re-educate the public and policymakers about the nature of addiction and the nature of the long-term recovery process and the nature of treatment in that. It will take years to transform acute care models into recovery-oriented systems of care. I'm glad Arthur Evans and others are here today to tell you, you're going to come into Philadelphia, you're going to visit Connecticut, you're going to visit the recovery centers in Vermont, you're going to look at some great stuff going on in Delaware and other places, and you're going to be very excited. But be sure and ask them in detail, what was this process like? Because you know what? It is ugly. It is messy. It is hard to do this work. And you think something's going to happen very quickly, and it is agonizingly slow at times. And just about the time you're ready to turn your back and say, this ain't working, all of a sudden something blindsides you and you're absolutely stunned by the level of transformation that unfolds before your eyes. I want to say, finally, that process will require replicating around the country these difficult processes that have gone on in Connecticut and in Philadelphia. I want to leave you with one image. When I entered addiction treatment in the late 1960s, if somebody would have told me, Bill, in your lifetime, you will see addiction treatment programs in almost every community in the United States. You will see DUI intervention programs in every community, and EAP programs in business and industries. And if they'd have said, you're going to see a First Lady of the United States on television talking about her recovery, and on, it would have been inconceivable to me in 1969. And yet, I lived that miracle, as many of you did, right? And then in 1976, where's Bob? NCADD sponsored a thing called Operation Understanding. Had 52 prominent Americans stand up and announce their status as people in long-term recovery from alcoholism. It was an amazing moment in American history. And if somebody would have told me in 1976, Bill, in your lifetime, you will see hundreds of thousands of recovering people marching across the country. Think about it. 1976, we had 52 people. Last year, we had 40,000 recovering people and their families and friends marching in recovery celebration marches last September in the United States. We as a treatment field are going to be challenged by a politically mobilized recovery community. And we can choose to heed that call or not heed that call. But I want to leave you with one warning. We are also on probation by that recovery community. They are looking at us very closely to see if we're really going to be able to pull off this rhetoric. Because I'll tell you, our reputation in their eyes has deteriorated dramatically over the past 40 years. But we're on probation now. They're sort of saying, we're wait and see. And some of them are getting excited and jumping in and helping us out. But if we do not respond to that call, this movement at this point, I think, is unstoppable. We may not be part of it. But if we're not, let me tell you the danger we face. The recovery community will give up on us. They will see us as money changers and throw us out of the temple. And what they will do is they will begin to organize a parallel system of long-term support that will not be our partners and collaborators, but will be our primary competition. And you know what? They can be our worst enemies. You know why? Because they include all the people we threw out of treatment. They know where all the skeletons are buried. Right with me? So we got a challenging job to do, and we got a critically narrow window of time to do it. I have been amazed at how quickly this understanding has unfolded in the field. And I see our presence here yesterday and today, and most importantly, who we have in this room today, as absolutely historical. This is a moment of time that, as Michael said, we can truly change the world. So let's go do it.